Well, the governor had been briefed on this issue, and she's received a number of letters, and local community folks in Larned who have communicated with her. She was prepared for our meeting, and what I conveyed was the importance of that critical access hospital license. If we're going to have a hospital in Larned, it's going to need that designation. And the problem is that there may be a gap. If the hospital is closed, that license goes away. And so what I asked the secretary to do was to explore every avenue by which her department and the Agency for Medicare and Medicaid Services could either keep that license alive or revive it once a hospital was there to replace the hospital that's closing. And the pleasing thing is that the governor expressed a strong interest in doing that. She, of course, understands the importance of a hospital in Larned and to rural communities across our state. And there are a number of hurdles. The biggest hurdle we face is that any critical access hospital has to be a certain number of miles away from another hospital, and Larned would not qualify in that regard. And so the question becomes, can we find some exception? At this point, that's not happened, but more meetings are now scheduled with the experts at the Department of Health and Human Services, with Kansas officials, with Larned officials, with me, and we're going to continue working to see if we can't find the ability for the governor, for the secretary to say this can happen. What I'm confident of is that there are a lot of people with good intentions and a desire to see a hospital remain in Larned, and I think that we can overcome all the legal and other hurdles that might be in place as long as we stay focused on the ultimate goal of getting a hospital either remaining or back in Larned. Absolutely, what's going on here in Washington, D.C. is important. Healthcare reform is an issue that we cannot walk away from. I'm one who believes that changes need to be made, but I'm not interested in arbitrary time deadlines that say we have to pass, for political purposes, a healthcare reform bill by the end of this month. This is a major undertaking with significant consequences, and to do something just for a political timetable or to get a headline in the paper that says Congress passes health care reform. I mean, we've been through this before. We saw this with cap and trade. In my opinion, we passed a terrible piece of legislation, and in part it was done without any members of Congress knowing what the details were of the legislation. That cannot happen again. In fact, I've signed a pledge, and this seems silly to me that one would sign a pledge, but what that pledge is that I will not vote for a health care reform bill until I've had the opportunity to read it, actually until I've read it, and the American people have had the opportunity to see that legislation on the internet for 72 hours. The reason I say that's silly is that no person, no member of Congress ought to have to sign a pledge saying they're going to do their job, but the reality is that the leadership in the House, with pressure from the Obama administration, has put these issues on such a fast track that I think we're making terrible decisions. Congress doesn't do its job well when we're methodical. We especially do our jobs poorly whenever we're under a rush. Let's do it right. This matters. It's not just about today and healthcare issues today. This has a lot to do with about healthcare into the future. Larned is a perfect example. We know what happens to a community when they lose access to health care and how it's so important to a community to maintain that service. And what I want to make certain that occurs in any health care reform debate here is that places like Kansas are not forgotten. Our issues are often access as well as affordability. Many people here in Congress never get to the issue of access. It's just a given. The hospital is there, the doors are going to remain open, the physicians are there, the nurses, the healthcare providers. You never have to worry about whether there's a pharmacy in your community, a nursing home. To us, it's entirely different, and I chair an organization here in Congress, the Rural Healthcare Coalition, 180 members of Congress, Republicans and Democrats, who are committed to making certain that this healthcare reform debate does not exclude or forget about states like ours. In addition to that broad issue about rural access, I also have a very strong opinion that any reform bill has to make certain that the physician and the patient and the patient's family are in charge of making decisions about the health care options that a person has. I do not want a national health care plan that turns those decisions over to somebody in Washington, D.C., some agency, some person who looks at your health care file and makes a decision whether you qualify for certain procedures, life-saving measures, or otherwise. So my two criteria in looking at health care reform that are certainly at the top of the list, although it's a longer list than two, but one is to make certain that rural issues are addressed for people who live in our state, and secondly, making sure that individuals and their doctors are the ones who are making health care decisions. You can have an insurance card that's going to pay for that health care, but unless you have access, and this is particularly true for senior citizens, and what we know is that if we don't keep access open, and unfortunately in many ways the federal government has a lot to do with whether there is access to health care in communities across our state. It's called Medicare, and when Medicare doesn't do things right, doesn't compensate our healthcare providers in a way that allows them to stay in business, we lose that access. And so you can be on Medicare and have a Medicare plan available to you, but if your hospital is 100 miles away or your physician is several counties down the road, what that means is that Medicare is not of value to you. You can't get there. And when that happens, we lose our rural communities. Young families don't take the risk of raising their families in places where their kids can't get in to see a doctor. And senior citizens reluctantly move away from their hometowns to larger cities where there is a hospital and doctors and other health care services. So this is about not only the health care, the quality of lives that we lead as individual Kansans, this is also about the survival and future of communities across our state. I think in addressing health care reform, and particularly the access to this to health care, that general family practice doc is critical. And what we need to make certain happens is that there is a Medicare and Medicaid reimbursement that covers our physician services so that they can continue to earn a living and practice medicine in rural communities. Our communities have a disproportionate share of senior citizens and people who are low income. Rural America suffers because Medicare doesn't reimburse to cover the cost, and so if you want to make a lot of money as a physician, you may not choose a rural community. Secondly, we need to make sure that our family practice docs are compensated for the services they provide in the office. We too much incentivize procedures. We need a family practice doc who can sit across from the patient and tell them how they need to change their lives to improve their health. And yet that's nothing that gets compensated today. So if you don't perform a procedure, if you don't have a test or send somebody to the laboratory, there's no money that comes from Medicare or Medicaid. So how we reimburse, how much, and what we reimburse for often determines whether or not we have access to physicians. And I also would add that we need to make certain that our medical schools, University of Kansas and otherwise, are admitting more students and graduating more doctors, and that we have financial incentives in place to encourage people to come and practice medicine in underserved areas. And you do that through scholarship and loan programs that help pay off the tremendous debt a student has in attending medical school. It's the way that we have physicians in many places across Kansas. There are state programs that are loan forgiveness, and there's a federal program that encourages physicians to come and stay in communities that are otherwise unserved. Our rural issues are often overlooked. It's just not an issue to most members of Congress whether or not there's a pharmacy in the town. It's just a given. And so our 180 come into play when there are those who are out looking for votes to pass a bigger piece of legislation. And so we will try to leverage ourselves to make sure that rural is not forgotten, that Kansas is not forgotten in this health care reform debate.